Okay, or the other one will be a OCT. So most of the pictures would be like this, a fundus retinal picture as you can see in 51, or subsequently we'll see the OCT picture also. Okay, I will tell you the significance and how to go about when there are images. Also, subsequently we'll revise the points. Okay, so this is a normal fundus picture. It is the retinal photo. Okay, so the retina is thin and transparent innermost layer. Okay, and when you see initially, whenever you're doing a clinical examination, you're going to see the red glow, fundus glow, which because the retina is thin, the fundus glow is because of the choroidal glow. Okay, then next you come to the disc. Okay, the optic disc. Okay, this optic disc is 1.5 mm in diameter, which is called as one disc diameter. So this optic disc size is 1.5 mm, which is also known as one disc diameter. Next, we see the fovea. After seeing the disc, we see the fovea, which is also of one disc diameter. Okay, the fovea, central fovea is also of one disc diameter size, and the distance between these two is two disc diameter, which is 3 mm. Okay, this is one disc diameter, fovea is one disc diameter, and the distance between this is 2 disc diameter. Now, fovea is a central part of the macula. So, the whole of this macular area is around 5.5 mm. Okay, 5.5 mm. Next, what do you see are these vessels. So, this vessel, which is thin and bright red in color, these are the arteries, and some purplish red in color, this is broader, these are the venules. So the venules are broader than the arterioles, that is why the ratio is 3:2. Okay, so usually it is venules are broader than the arterioles, which is 3:2. So this is the normal fundus picture. So before we saw the anterior segment photos to diagnose the anterior segment pathology. Now, something like this comes up, you should just imagine a retinal pathology. Okay, think of a retinal pathology. Now, retina is a transparent layer, but it has 10 layers. So, 52 VSV is layers of retina. Okay, so we know that it has 10 layers. The outermost layer is the retinal pigment epithelium, which is responsible for the metabolism. Okay, outermost layer near to the choroid is the retinal pigment epithelium. So you have the choroid here. So rest 9 layers are known as the neurosensory retina, which is for the electrical signal transmission of the visual output. So whenever there is a visual input, so it is converted into electrical signals and it is passed to the optic nerve by these 9 layers known as the neurosensory retina. So whenever there is a neural transmission, you know that there are 3 orders of neurons in the neural pathway, right? So it is a first order neuron, second order neuron, and a third order neuron. So in the retina, first order neuron is layer of rods and cones. Layer of rods and cones, they are the initial part which is absorbing the light, so it is the first order neuron. The second order neuron is the bipolar cells, by 2, second order, so bipolar. So remember, bipolar cells is the second order neuron. The third order neuron is a ganglion cell layer. Gang, at least you need 3 people to be a gang, so it is ganglion cell layer, which is the third order neuron. The first order is layer of rods and cones, second order is bipolar, third order is the ganglion cell layer. So these 3 neurons will form the neural pathway, as you can see here in this. Okay, so rods and cones are present, bipolar cells and the ganglion cells. Okay, the internal limiting membrane is the innermost layer, which is the basement membrane. Now, when you revise all these 9 layers, the outer part is the retinal pigment epithelium. Then comes the photoreceptor layer, which has the inner segments and outer segments of the rods and cones. Okay, inner segment and outer segment of the rods and cones. Then there will be an external limiting membrane, and the outer nuclear are those with the cell bodies of the rods and cones. Okay, cell bodies of the rods and cones. Then they form a plexus, which is the outer plexiform layer. Then the inner nuclear layer, which contains the bipolar cells and amacrine cells and horizontal cells. Inner plexiform layer, ganglion cell layer, retinal nerve fiber layer, and internal limiting membrane. Now, you see 2 more cells here, right? Amacrine cells and horizontal cells. Already we saw 3, first order, second order, third order. Other than that, there are 2, amacrine and horizontal cells. So amacrine cells is involved in feedback inhibition, And horizontal cells is involved in lateral inhibition. Remember, this horizontal cells is useful for the contrast enhancement. We already saw that vision has contrast sense also. For this contrast enhancement, this horizontal cell is cause a horizontal lateral inhibition and cause a contrast enhancement. Amacrine cells is for feedback inhibition. Now you may get a histopathology also to diagnose, to identify which layer is what. Okay, as a question. So when you see this diagram in close, this picture, so you can see this lumens, right? Whitish area are lumens. So these are blood vessels, and whenever this lumen is present, this is choroidal lumen. Choroid. Okay, so this is choroid. And next comes the RPE, you know. So RPE, it is very highly pigmented. Okay, and then the plexiform layer, which is the, photoreceptor layer, which is the rods and cones. This rods and cones have these striations. These are the inner and the outer segments of the rods and cones, not the cell bodies. So these striations are the photoreceptor layer, rods and cones. And then you will have the limiting membrane, which is not very significantly seen here, but you see here nucleus, right? Nucleus, cell bodies with nucleus. So this is the outer nuclear layer. So if you find any one of these layers from the outside, then subsequently you can also find the other layers which is marked and identified. So choroid will have lumens, highly pigmented is RPE, retinal pigment epithelium, striations will be rods and cones, and next comes the nuclear layer, which is the outer nuclear layer, which is the cell bodies of the rods and cones. So this is about the layers of retina. Now, I already mentioned that you will have a fundus picture or a normal OCT. OCT is what? Optical coherence tomography. Okay, so this optical coherence tomography is a non-invasive and non-contact investigation. Okay, you're just going to place the chin, the patient will place the chin and you're going to measure it with an instrument. That is non-invasive, non-contact, and it uses a near infrared interferometry, which is a low coherence interferometry. And this is the most important part. OCT is mostly done to diagnose, monitor, and treatment of macular diseases. Whenever a OCT is present in your question, then think of macular pathology. So this is important. Okay, and depending, whenever a light goes through something, depending upon the reflection, you will have highly reflective, intermediate reflective, and low reflective. So this highly reflective structures are due to the presence of melanin. Depending upon the melanin concentration only, this structures will be reflected. So highly reflective colors will be in red. As you can see here, this is a red color, which is the RPE, and then you have the layer of rods and cones also. Okay, photoreceptor layer. Okay, photoreceptor layer is also in red color, and you have here nerve fiber layer, right? This is a nerve fiber layer. Okay, so this nerve fiber layer is present in red color. So all these three are present in red color. Okay, you can see here, and the intermediate is the green to yellow color, where it will be the plexus. And low reflectivity is due to blue or black in color, which is the nuclear layers or other structures like fluid also, like vitreous, this choroidal lumen, and any cystic spaces of fluid will be in blue to black in color. Okay, so this here, this area is the vitreous, this is the choroidal lumen, and this U-shaped, this is the normal foveal contour. Okay, U-shaped normal foveal contour. Okay, so this is the normal OCT pattern. Now, VSV 54. Now, whenever there is a retinal picture, as you can see here in this, you have hemorrhages here, right, all over, and exudates are this yellowish color. So this is a non-proliferative diabetic retinopathy. Now, four features are present in this: microaneurysms, Intraretinal hemorrhages, hard exudates, and cottonwool spots. Microaneurysms is the first detectable lesion, and it is due to outpouching of the capillaries due to loss of pericytes. The blood vessels will have the pericytes which will get lost. Okay, due to the loss of pericytes, there will be outpouching of the capillaries. So that will be the microaneurysms, and it is seen in a nuclear layer. Okay, so the intraretinal hemorrhages. Now, see, microaneurysms are there and they are going to break and form hemorrhages. So, this is the rupture of microaneurysm causing intraretinal hemorrhages, which can be dot and blot hemorrhages and superficial flame shaped hemorrhages. Now, dot and blot hemorrhages are characteristic of mostly diabetic retinopathy, and there might be superficial also. So, dot and blot in inner nuclear layer again, superficial is in nerve fiber layer. Okay. Now, next you see, as you can see in this diagram, you have the hemorrhages and microaneurysms, which are actually difficult to differentiate much. Okay. Now, the third one is the hard exudates, which are the lipoproteins, which is in the outer plexiform layer. So, the lipoprotein exudates are this hard exudates, which are small, well defined, and usually concentric around macula. Okay. So, this is the hard exudate. Now, when it comes to the cottonwool spot, this is due to the axonal depress due to the ischemia, which is found in the nerve fiber layer, and these are ill-defined and fluffy. Okay, these are ill-defined and fluffy. One more thing, what you have to remember in the non-proliferative diabetic retinopathy is clinically significant macular edema, CSME. So, come to this diagram. Okay, this image. So this part you have three. So you have three things that can be a clinically significant macular edema. When there is a retinal thickening, okay, within 500 microns of center of macula. As you can see here, this is a retinal thickening within 500 microns of center of macula. The other thing would be a hard exudates. You can see this yellowish hard exudates plus retinal thickening again within 500 microns of center of macula. The last thing would be retinal thickening of one disc area within one disc diameter of center of macula. Okay, this is one disc and this is a one disc diameter from the center of the macula. So any retinal thickening of one disc area within one disc diameter of center of macula. So this is about clinically significant macular edema. Now, how do you treat if you have a clinically significant macular edema? Then you give a intravitreal anti-VEGF. Okay. So that is about non-proliferative, and whenever these are occlusive conditions, like so, whenever there is a non-proliferative, then the next stage would be a proliferative diabetic retinopathy. Why is the term proliferative? That is because the vascularization, that is the vessels which are forming new due to the hypoxia, it is going to proliferate, neovascularization. So as you can see here, these are new vessels. Right, these are new vessels, which is known as the NVD, neovascularization of the disc, because the disc is here. And here in the periphery, you can see some neovascularization. So, which is neovascularization elsewhere. Okay, so anytime this neovascularization is present, it is proliferative diabetic retinopathy. This neovascularization, this rupture of new vessels can cause vitreous hemorrhage. And here there's a boat shaped hemorrhage. This is a pre-retinal hemorrhage or a vitreous hemorrhage can occur. Okay, so this pre-retinal vitreous hemorrhage and neovascularization is characteristic of proliferative diabetic retinopathy, and this will cause a fibrovascular proliferation. And due to this fibrovascular proliferation, this will contract and this will cause a tractional retinal detachment. This can cause a traction, this can cause a tractional retinal detachment. And after the posterior segment neovascularization, the neovascularization occurs in the anterior segment, which is rubeosis iridis, that is neovascularization of the iris, NVI, and then it can lead to NVG, neovascular glaucoma. So the treatment would be a pan-retinal photocoagulation. So you are going to stop this hypoxia by this pan-retinal photocoagulation. Okay, this laser you can see, and intravitreal anti-VEGF. Okay, if there is associated macular edema, then you can give intravitreal anti-VEGF along with pan-retinal photocoagulation, which we call it as PRP. So this is about proliferative diabetic retinopathy, non-proliferative and proliferative diabetic retinopathy. 56 VSV is hypertensive retinopathy. So now there are 4 grades. Grade 1 is mild to moderate narrowing of the arteries. So you can see smaller arterioles, narrowing of the smaller arterioles. Grade 2 is, along with narrowing, you have AV nicking. Okay, this is the narrowing of the veins at the AV junctions. AV nicking, okay, narrowing of the arteries at the AV junction, that will be causing a AV nicking, okay. So now grade 3 is that along with this AV nicking, you will have hemorrhages which are flame shaped. Now remember, flame shaped is mostly found in hypertensive retinopathy. So flame shaped hemorrhages and cotton wool spots, these are ill defined fluffy margins, right? Cotton wool spots in grade 3. In grade 4, papilledema, disc edema. Whenever there is a papilledema and hypertensive retinopathy, then that's a grade 4. Okay, AV nicking is grade 2. Grade 3 is cotton wool spots with flame shaped hemorrhages. Grade 4 is all these with optic disc edema. This is papilledema. So pathogenesis already you know, in hypertension it is vasoconstriction, arteriosclerosis, and increased vascular permeability. Remember all these grades. Now, another form of occlusion is that sickle cell retinopathy. Now, in what is happening in sickle cell anemia is that there will be abnormal shaped rigid blood vessels. So, okay, blood cells. So, these blood cells, when they come into the flow, they will go and cause occlusion of the blood vessels, small blood vessels, right? So, in eyes also, they will go and block the small blood vessels, causing retinal hypoxia. So, what will happen? There will be a non-proliferative and a proliferative stage. A non-proliferative stage, you will have a Salmon's patch. Okay, sickle cell, remember SS, it has a salmon patch appearance in the retina, so it is non-proliferative. It is sickle cell retinopathy. And the other thing is the C-fan neovascularization. This comes from the name of a coral. Okay, proliferative stage, you have this neovascularization here. This is the C-fan. So sickle cell retinopathy, Salmon patch, and C-fan neovascularization, SS, right? Now, next is what? You see again, you see the picture here, okay? You see a fundus photo. And what you see major here is that multiple superficial white retinal patches. So you can see superficial white retinal patches. These are Pusher's fleckens. Okay, these are Pusher's fleckens. This is Pusher's retinopathy caused by the embolism or vascular occlusion again by WBC's aggregation. So whenever you remember this, multiple superficial white retinal patches, Pusher's retinopathy. Okay, and you might have associated hemorrhages, disc swelling, cotton wool spots, and Pusher's fleckens is caused by severe chest trauma, long bone injury, amniotic fluid embolism, and acute pancreatitis. Okay, so these things will cause the occlusion, okay, vascular embolism. Remember, anytime you have a long bone injury or a chest trauma, the cause for the chances of embolism is high. So it will go into the retina also. So it will cause the Pusher's retinopathy. Okay. Now, again 59, you can see the fundus picture with retinal hemorrhages. Now, what are special in this retinal hemorrhages is that you have a center white area. Center white area here. So, retinal hemorrhages with white centers is rot spots. Okay, rot spots. This white centers is due to the coagulated fibrin. Okay, this white centers is due to coagulated fibrin, and this is seen in acute leukemia, subacute bacterial endocarditis, and can be seen also in diabetes and hypertension. So acute leukemia, rot spots, retinal hemorrhages with white centers. White centers is due to coagulated fibrin. Now coming to VSV 60. No, just don't see the topic, just see the diagram of image. So what do you see? It is a fundus picture you can see, and it is full of reddish color. This is a splashed tomato appearance. Okay, splashed tomato appearance. And yes, you are right. This is central retinal venous occlusion. This is not artery. This is vein. So this is central retinal venous occlusion, which has the splashed tomato appearance. This is the second most common vascular disease. Now, this occurs due to arteriosclerosis of the retinal artery. So, how come a retinal artery arteriosclerosis will cause a venous occlusion? Because in branched vein, you know already the AV crossing is there. So, there the arteriosclerosis of artery will compress the vein. So, that compression of vein at the AV crossing will cause the branched retinal vein occlusion, which is the BRVO. And in the central retinal vein and artery has a common adventitious sheath. So in that also the thickening arteriosclerosis of the retinal artery will cause retinal vein occlusion, which is the central retinal vein occlusion. Now remember, there will be a sudden painless decrease in vision. When you see the anterior segment will be normal, splash tomato appearance, it could be associated with macular edema. And after around 90 to 100 days, there will be neovascularization of the iris, which will form the neovascularization glaucoma. Remember, 100th day glaucoma. Okay, this term is usually used. So, central retinous venous occlusion can cause NVI and NVG, which is the 100th day glaucoma. Okay, now the treatment would be what? So in treatment would be you can do a PRP to reduce the occlusion and all. I mean to reduce the hypoxia. The main thing is that you have to give an intravitreal anti-VEGF. If it is resistant, we give intravitreal steroids also. So this is central retinal venous occlusion, splash tomato appearance, 100th ray glaucoma. Now, next is again you see a fundus picture. So what do you see here? It is a pale retina. You are not seeing the normal glow. It is a pale retina. Whenever you are anemic, I mean, remember you have less blood flow. That means what? Arterial occlusion. So central retinal arterial occlusion will have pale edematous retina, which you can see here, and a characteristic cherry red spot. This is a cherry red spot over the macula, and the narrowed arterioles will show a cattle truck appearance. Okay, cattle truck appearance. So pale edematous retina, cherry red spot, cattle truck appearance, central retinal artery occlusion. And this most common cause is atherosclerosis related thrombosis, and 20% is embolus cases, which is Hollenhorst plaque. Now, the most common level of occlusion is at the level of lamina fibrosa, and the patient will present with severe reduced visual acuity. There will be a relative apparent pupillary defect, which is RAPD, and this is an ocular emergency. Now you know that MI, stroke and all, you have some ocular emergency times. Similarly, central retinal artery occlusion, it is within 4 hours. Okay, it is within 4 hours. And how do you treat it? You do an ocular massage to dislodge the embolus and reduce the IOP. Okay, ocular massage. And to reduce the IOP, you are going to give a tablet acetazolamide and an anterior chamber paracentesis. Okay, so this both will reduce the IOP. And rebreathing in a paper bag, what does it happen? It causes a respiratory acidosis, and in turn it causes vasodilation and dislodging the embolus. Okay, so pale edematous retina, cherry red spot, cattle truck appearance, central retinal artery occlusion, ocular massage, acetazolamide, anterior chamber paracentesis, or respiratory acidosis, rebreathing in paper bag to cause vasodilation. Now, another important topic is retinopathy of prematurity. So, it is done in newborns. So, where do you do? Whenever a newborn is less than 2 kgs, 2000 grams, less than 34 weeks of period of gestation, and if 34 to 36 weeks of gestation, if they have respiratory distress syndrome associated abnormalities. Okay, so less than 2000 grams, less than 34 weeks of period of gestation, 34 to 36 weeks if associated with respiratory distress syndrome. Now there are stages for this. So stage 1 has a line. Okay, this line of demarcation between the vascular area and avascular area. Stage 2 has a ridge elevated thing between the vascular and the avascularized area. Now, stage 3 is neovascularization. Okay, neovascularization, you can see the blood vessels in this ridge. Okay, and stage 4 is retinal detachment. Now, 4A is extrafoveal retinal detachment, and stage 4B is foveal retinal detachment. Now, something you have to remember here is the plus disease, where you have the dilation and tortuosity of the blood vessels in at least two quadrants of the posterior pole, and this means faster progression. Okay, this means a faster progression of the disease, plus disease. Other thing you have to remember here is the zones of the ROP. So, in the eye, you have a disc, you have a macula. The first zone would be, zone 1 would be, the radius of the circle would be twice the distance between disc and center of macula. Okay, so this is zone 1. Then, including the nasal ora serrata, you have the zone 2, and zone 3 is the rest of the temporal part. Now, one thing to remember here is that zone 1, you know that twice the radius of distance between center and disc of the macula. Zone 2 is still the nasal ora serrata, that's radius, and zone 3 is the temporal. Zone 1 has the disc and the macula. So, always here, whenever there is a disturbance, you give anti-VEGF. You do not laser. And rest of the things, to zone 2, zone 3, you can laser. Okay, and whenever there is an RD, retinal detachment, you have to do a pars plana vitrectomy surgery. Okay, pars plana vitrectomy surgery. This is about retinopathy of prematurity. Now, 63 VSV is, what do you see here? You see here retinal telangiectasias. This is again a fundus picture. You see the retinal telangiectasias and aneurysmal arteriolar changes. Okay, retinal telangiectasia with aneurysmal arteriolar changes, and these are intraretinal exudates. This is Coates disease. Retinal telangiectasia, atenular arterial changes, and intraretinal exudates is Coates disease of early childhood. It is one of the differential diagnoses for leukocoria, whitish reflex, what you see, and it can cause exudative retinal detachment. You can see here exudates forming, right? So this can cause an exudative retinal detachment. Treatment would be laser ablation of the exudates, which can help, and anti-VEGF and intravitreal steroids can be given. So Coates disease is early childhood, retinal telangiectasia, aneurysmal arterial changes, and intraretinal exudates. Retinal telangiectasias and intraretinal exudates. Now coming to VSV 64. If you can see this diagram, then you have a specific thing. What you see here, it is a fundus picture, and what you see B is a OCT. Now remember OCT, think of macular pathology. Okay, so just see in the first one, you can see that there is a hole over the macula. It is not normal. And when you come to the OCT, there is a full break here. Okay, so this is a full thickness macular hole. Full thickness macular hole. Most common causes idiopathic. Others would be vitreomacular traction. When the vitreous is producing a traction at the macula, it can cause full thickness macular hole. Or high myopia or blunt trauma can also cause a full thickness macular hole. Okay, so the investigation of choice is what? Now we saw here OCT, optical coherence tomography. Okay, now a clinical test is there, which is the Watsky-Olin test. So what you are seeing here is not a clinical, it is an investigation. So what do you do is you produce a beam of light, narrow beam of light over the center of the macula. Okay, over the macula you produce a beam of light. So actually normal patient would see a straight beam of light. But in case of a macular hole, what will happen is that the patient will see a break in the center. So this break in the center will be present due to the macular hole. So This is the Watsky-Allen test. And the treatment will be vitrectomy, pars plana vitrectomy with ILM peeling. Now, ILM is the internal limiting membrane, is the innermost layer of the retina, right? So you have to peel it and you have to stuff it inside this hole. So you can close the hole. That is vitrectomy with ILM peeling. Now next we go to 65. So VSA 65 again has fundus pictures. Okay, fundus picture. What do you see here? This is age-related macular degeneration. So it has two types, dry or atrophic, wet or exudative. Okay, so dry type is most common. It occurs in 90% of the population. But wet is more severe. More aggressive is the wet, more common is the dry. Okay, so in drusen, so what is a drusen? These are the drusen. You can see this yellowish material, right? In age-related macular degeneration, you have drusens, which are extracellular deposits between retinal pigment epithelium and Bruch's membrane of choroid. Okay, so retinal pigment epithelium and Bruch's. So between that, there will be extracellular deposits. These are the drusens. Okay, so if you can see here, this is atrophic type. You can see drusens around the macula in the A. In B, if you see, you can see humps in the OCT, humps, right? And this is again due to the drusens. So drusens are present where? Between the RPE and the Bruch's. So sub-RPE. So the humps are going to be like this. So this is going to be due to the sub-RPE drusens. So whenever these drusens are going to expand, they are going to form a geographic atrophy. Okay, this is a geographic atrophy. You can see it has coalesced, it has expanded to form this geographic atrophic area over the macula. So this is the dry part. Okay, dry part of AMD, and the treatment would be what? Atrophic. Antioxidants. We have the ARH2 formula for the antioxidants which we use. Okay, now the wet part, we come to the exudative part where you can see this diagram. So there is neovascularization, right? This blood vessels are seen and this bleeding is seen. So new vessels come from the choroid in exudative type. And here, if you can see the OCT, there is a membrane here. This is choroidal neovascular membrane. Okay, this is choroidal neovascular membrane. We call it as CNVM. Now for the wet thing, we have to treat it, like we have to give anti-VEGF. So the anti-VEGF what we use is ranibizumab, aflibercept, brolucizumab, newer one is a faricimab. Okay, ranibizumab, aflibercept, brolucizumab and faricimab. Now bevacizumab is there, which is off-label, so it is actually used, but it is should not be used. So this is a off-label drug. Okay, bevacizumab is an off-label drug. So age-related macular degeneration, dry or wet. Dry has drusens, humps in the OCT, sub-RP drusens, geographic atrophy, and you have the ARH2 formula antioxidants as the treatment. In exudative, you have the neovascularization, choroidal neovascular membrane. We give anti-VEGF, ranibizumab, aflibercept, brolucizumab, and faricimab. Bevacizumab is off-label. So coming to 66th VSV, here is central serous retinopathy. So the name itself says it is central. Now remember, again you're seeing a OCT. So this is macular pathology. So the central over the macula, there is a serous retinal detachment. Okay, this is a serous retinal detachment over the macula. You cannot see the normal foveal contour. You can see normal macula is not there. It is elevated, and this black space is the fluid. That is why it is called as a serous retinal detachment. And when you do a fundus fluorescence angiography, here you can see an ink blot appearance. Okay, ink blot, and here you can see a smokestack appearance. So ink block, smokestack appearance, and OCT showing a serous detachment. It is central serous retinopathy, and it is mostly idiopathic localized macular serous detachment. We call it as central serous retinopathy. Risk factors. Remember, males, young males, type A personality. What will happen to all this type A personality? They'll be very stressed. There'll be increased stress steroids. So the other way of that is steroid usage. So if you consume steroid externally, also it can be there. And young males or type A personality will also can have this central serous retinopathy. This is a high steroid condition. Okay, and H. pylori infection can also cause it. Okay, so what do you do for the treatment? Observation. Okay, mostly it will settle, and if the patient is using steroids, then you have to discontinue steroids. Okay, and oral spironolactone is given as medical treatment, but due to some disadvantages like side effects, nowadays we use eplerenone 25 to 50 mg OD. Okay, 25 to 50 mg OD eplerenone we are using as a treatment to central serous retinopathy. Other thing is also lasering the site of leakage. So serous retinal detachment with ink blot appearance, smokestack appearance, central serous retinopathy, CSR, young males, type A personality, steroid use, discontinue steroids, can give eplerenone or spironolactone. Now, what you can see in 67th photo, first image is that yes, it is a OCT, so suspect a macular pathology. You have lost some normal foveal contour. No, it's not a normal macula. What you see here is cystic spaces, fluid containing spaces in the outer plexiform and inner nuclear layer. Okay, so this is cystoid macular edema. There is a loss of foveal depression and retinal thickening with hyporeflective. This is hyporeflective cystic spaces. And when you do a fundus fluorescence angiography, you have a petaloid appearance. Okay, petaloid appearance in fundus fluorescent angiography. This is cystoid macular edema. The patient will have decreased vision, distortion, and micropsia. Micropsia means small images. So micropsia is a feature of cystoid macular edema, and when it is occurring post surgery, post cataract surgery, it is called Irwin gas syndrome. Okay, and the treatment would be topical non-steroidal anti-inflammatory drugs or topical corticosteroids. When it progresses, then we can give intravitreal steroids also. Okay, so just give me a minute.